What are the key priorities for the Office of National Coordinator for Health IT? How is it transforming the adoption and use of health IT? And how is the U.S. healthcare system continuing to progress toward value-based care to improve quality and patient outcomes? I'll explore these questions and so much more with my very special guest, Dr. Micky Tripathi, National Coordinator for Health IT within the U.S. Department of Health and Human Services. I was wondering, Micky, if you could share with us, what are some of the, let's say, top three maybe challenges you face in your current role, and how have you sought to address them?
Yeah, absolutely. The first is budget. Our responsibilities are increasing dramatically, but our budget has remained constant really since 2004 in many ways. In 2004, the ONC budget was $52 million. And I remember that very well because I was launching an organization called the Massachusetts eHealth Collaborative in Massachusetts, and we had a $50 million budget just for three communities in Massachusetts. And I was joking with David Brailer at the time, who was the first national coordinator, that he had a $52 million budget for the entire country. And so that was in 2004. And then, as I just described, our budget last year was $66 million. Like if you just in real terms made that $52 million real dollars, that would get you up to over $90 million in real dollars. So in a very real way, we've actually had a budget decrease over that time period. Now, we certainly had an up and down during the meaningful use era where we had, the certification program to put in place. And, so I don't want to pretend that didn't happen. But in terms of our operational day-to-day responsibilities, that's grown dramatically. If you think about, the increasing demands of the certification program, TEFCA, Trust Exchange Framework and Common Agreement, the information blocking provisions, requirements for new standards that all came out of 21st Century Cures Act that were fantastic. I mean, we were very pleased that the Congress had such confidence in us to vest in us those responsibilities. But it would have been great to have gotten budget to do those things. And we got no budget. So that's the first challenge that we have, is that we've got an increasing set of responsibilities. And as I said, the department and this administration have been fantastic in putting, requests for additional dollars in the president's budget. We just haven't been able to see that all the way through the congressional process. So that's the first challenge. The second challenge, I would say, is what I would say is just extreme risk aversion of the federal government. And, and what I mean by that is there's just a lot of risk aversion, particularly from a legal context, in terms of, the willingness to take policy risks and take risks around things that in the process itself, where you've got a lot of federal career employees who are fantastic. This isn't a criticism, but just by its nature, that creates risk aversion to taking, certain set of policy risks, for example, that there may be concerns that, well, is that going to endure over time? Is that going to endure over this particular administration? Is that going to endure over this particular agency head? And then, of course, you have very, very sensitive risk assessments that come from the legal side that make the federal bureaucracy, I think, my personal opinion, more risk averse than we should be, because we need to be taking a certain balancing of risks in order to accomplish policy goals. The American people have real needs and real wants from us, and if we take the most risk averse position every single time, we're not going to come close to meeting their expectations for being able to get things done. So I think that's the second challenge, I would argue, is just that risk aversion and doing everything we can to have an appropriate balancing of it and fighting that natural instinct. The third is we've got really long and complex regulatory cycles in the federal government. And, we ONC, we're sort of at the frontier of technology and business change in a very rapidly changing ecosystem. And it's really hard to have these long and complex regulatory cycles that don't keep up with the pace of technology and business change. So we're always caught in this dilemma of putting things in regulation that actually aren't going to come out for another 2 years and trying to anticipate, well, where is the market going to be then? and you're often wrong, right? You're often not exactly right, because the market is very dynamic and goes in different ways. And so that's an ongoing challenge, I think, is trying to figure out, how do you work with industry with sub-regulatory kind of things, helping to get, leading indicators from industry, helping to set appropriate guardrails that can channel things in certain directions, but leave flexibility for the changes that are going to happen, but you just don't know exactly how they're going to unfold.
Micky, just for the audience, health information technology, health IT, simply refers to the use of information and communication technologies in the caring for patients. And I was hoping you could tell us a little bit more about your strategic vision for the office, and maybe even more importantly, tell us your priorities.
We group our priorities into kind of four areas. Just by way of just remind everyone of one of the things we were talking about before about how the trajectory of health information technology has advanced so much over the last 15 years. That a big part of the work starting from 2010 with the High Tech Act, the Meaningful Use Program, all of that was just building that digital foundation. We had, 10% of providers, I think, on electronic health records in 2010. We were the clear laggards of the industrialized world. All of our industrialized peers were way ahead of us in the adoption of health information technology. And through the Meaningful Use Program, through the High Tech Act, and all the investments and incentives provided by the federal government, as well as the money and the blood, sweat, and tears of providers and others and health IT developers putting into place that vision, we accomplished that building the foundation. So a first part, so our goals, the way we think about that with that context are, one, continuing to build on that foundation. So we've got that foundation, but you need to keep raising the floor on that. So increasing, sort of the standardization of data and the availability of standardized data from those systems, for example, filling in the gaps that program didn't fill. So hospitals, something like 97% of hospitals now use certified electronic health record systems. 86% of physician offices use certified electronic health record systems. Again, over a relatively short time, 13 years, where 10% prior to that used it. Now we've kind of flipped that equation so that almost all are using it. But there are still gaps. Behavioral health, substance use disorder clinics, long-term care, nursing homes, rehabilitation hospitals, psychiatric hospitals. We've still got a lot of gaps, and that's a part of that building that foundation. So we're working hard with our agency partners and others to say, what levers can we use to continue to fill those gaps and to make sure that foundation is a rising floor, so it's not static, because that's got to keep pace with industry. Second, so the first is build the digital foundation. The second is make interoperability easy. So you've got these systems now. Everyone's got a system, but how do you make it easy for them to exchange information with each other? So we've got APIs and API-based approaches, application programming interface, for those who aren't familiar with that term, that allows systems to connect with each other in modern ways and really interact with each other in a dynamic way. For those who aren't familiar with this, it's, just look at your smartphone, and all the apps you have on your phone are APIs in the background that are really easy to use. They're lightweight, they're configurable, they're awesome ways for you to accomplish interoperability. We want healthcare to finally discover the internet and have, API-based information exchange. And then the second thing is TEFCA, the Trusted Exchange Framework and Common Agreement, which is network governance. Think of, again, another analogy that people are familiar with. Think of the way cell phones work today. We think of our cell phone network across the country and indeed around the world as being a single network, when in fact it's multiple networks that are connected with each other. We have, just in the US, we have AT&T and Verizon and Sprint and T-Mobile and Cricket and all of these, different networks. They all connect with each other. When we purchase a phone, we don't worry for a second about, is my phone going to connect with Michael's? It's like, well, no, it's absolutely going to connect, even though they're two different vendors, two different networks. That's what TEFCA is designed to provide, is that connectivity in the back end, so that you as a user, you're using the CHR system, it's connected to whatever network it's connected to. You should have the assurance that doesn't matter, that you can connect to any other EHR system, regardless of what network they're on. So that's the second one. First is continue building the digital foundation. Second is make interoperability easy. Third is encouraging people to use that interoperability. Because, one of the things that we've seen is that just because you build it doesn't mean they will come. We can put in place the technologies, we can make it easy for them to interoperate with each other, but there's still, there's hesitation from business, business competitive reasons, but there's also just priority issues. I mean, lots of provider organizations, it's not just the technology. They would have to change their workflows. There's a lot of workflows that are built into just faxing stuff to other provider organizations, or just handing the patient a stack of paper record and saying, here, you take this to the specialist. As much as we want to get rid of that, we, need to appreciate that, yes, you can make the technical mechanisms for that, but if you're going to do that in a safe way and an efficient way, there's some workflow changes that are required as well. But that takes encouragement right? That takes encouragement. So that's things like the information blocking rule, for example, that basically say to organizations, you know what, you have an obligation to share information with other parties and with patients using electronic mechanisms, not just handing them stacks of paper. And then the final thing is, it's building the digital foundation, make it easier to interoperate. And then finally is the guardrails on the other end of it, which is now that we're sharing information, how do we make sure that we've got appropriate guardrails on that end? So focus areas like health equity, for example, to make sure that the data that's being exchanged is sensitive to the different communities that we have, and to make sure that we have an ability to assess whether we're doing right by all the communities that are in this country, and the ability to put in place mechanisms to rectify areas where we may have health inequity. And then, of course, it wouldn't be a healthcare or any kind of conversation if I didn't mention AI. AI is another area that we have a lot of focus in, which is to say, how do we make sure that algorithms are appropriately using the interoperability, the data that's made available through electronic health information, to the best benefit of the patients and not to their detriment.
I was hoping you could tell us more about the progress around the implementation and use of the information blocking provisions in the Cures Act. How has this information blocking necessitated the change of culture in how information is shared across the continuum of care in the health ecosystem?
Yeah, it's something that has taken a while to ripen, I would just say, because it's, the 21st Century Cures Act was passed in 2016. Remember, 2016, and here we are in 2023. We came into office in 2021, and literally none of the components of the 21st Century Cures Act related to that were specifically, assigned to ONC had been implemented. So there's a lot of work to do in a relatively short time to say, wait a minute, we need to rectify this and get the very important act that had very strong bipartisan support on both sides, both chambers of Congress, as well as both parties in 2016, to get that implemented. That was very strong sentiment that this was important for the American people. So information blocking was a big part of it. And just to level set, the information blocking provisions basically say that you cannot interfere with the exchange of what's called electronic health information between authorized parties, meaning parties that are already authorized to have access to that information through applicable law. So it didn't open up any new avenues for information sharing. What it said is that if you're already authorized to share information with that other party, like a primary care physician and a specialist, or a physician and a health plan, or a physician and a patient, that if you're already authorized to do that, you're obligated to do that. That isn't like a choice. You shouldn't feel that that's a choice. You should feel that you have an obligation to do that. That's what the information blocking rule said. And that you can't interfere with what was seen as that should be a natural flow of information. That shouldn't be, something that's gated. That should be something that flows naturally and is only gated under specific conditions. So anyway, so ONC came in. We, on April 5th, 2021, we put that final rule into place, which set the policies for the information blocking, framework, and specifically said, defined information blocking, and it defined exceptions, as they're called, where an actor could say, well, here's why I'm not sharing the information. But it's fairly explicit, and says there's only 8 reasons that you can have for not sharing that information. And by the way, if you don't share the information, you have an obligation to kind of document, why you didn't, so that you can actually stand up to that if you're ever challenged on why you didn't share that information. So in terms of the progress, we the first part of it was April 5th, 2021, which was to share a minimum data set. The US CDI was the minimum requirement, the US Core Data for Interoperability. And then on October 6th, 2022, which was 18 months later, the requirement went into effect for what we call all electronic health information, which the statute defined as all electronically accessible information, which is a lot of information. And so in terms of, where we are there, I know there's a long story, but let me just describe. There's a little bit of complexity here because the statute left open certain things that we're now working hard to close. One was they directed ONC to essentially establish the policy for information blocking, but they authorized our sister agency, the Office of Inspector General, to do enforcement. So that was one. Now you have 2 agencies that are coordinating. Each agency has to do its own rules. So ONC got our rule out on April 5th, 2021. The OIG role on enforcement wasn't finalized until just July 7th, I think, of this year was when they put their final rule out. So that was, that was an important piece of the puzzle, right? Because, April 5th, 2021, we basically said to industry, you're required to be in compliance with this now. But of course, industry is looking at it and thinking, well, there's no enforcement defined. So how much should I really pay attention to this? Now, I don't want to say that people were doing that. I mean, everyone, I think, was moving forward saying, okay, yes, I need to be in compliance. And we're certainly hearing from a lot of compliance officers about, hey, how do I do this? So it's certainly the industry was moving forward. But I think as all of us would appreciate, until enforcement is really in place, that's when you really pay attention. It's like, oh, okay, now people are watching, and I actually could be fine. So that's the first thing. The second is that the law didn't specify penalties for providers. So who's subject to the law? There are three actors: health IT developers, which is like the Epics, Cerners, Athena Health of the world; health information networks; and then the third is providers. Now, just as an aside, payers were not named as actors. That was in the statute. So just as a point of reference for everyone, for whatever reason, the Congress didn't include payers in that. So payers are not obligated to share information under information blocking unless they are like a health information network or they're a provider. As we know, a lot of payers are also providers. So in their context as a provider, then they certainly are, but in their context as payer, they are not. But for those three actors, the law said that we're going to give the authority to the Office of Inspector General to assess civil monetary penalties of up to $1 million per incident, which is a real fine. I mean, if you compare that to like HIPAA fines, for example, that's a really strong penalty. But they said that only applies to technology developers and health information networks. For providers, what the law said is there will be appropriate disincentives that we are not going to define. We're going to leave it to the Secretary of Health and Human Services to define. And the Secretary of Health and Human Services has to do it within existing authorities. So we're not going to give the Secretary any new authorities to do that. So that was really complicated. So we came into office, that wasn't defined. No progress has been made on that. So we've been working really hard to work with the Secretary's office to say, all right, how are we going to do that? We have announced, and it's in the federal regulatory schedule, that we are going to be publishing a draft rule in the fall of this year, which will be our draft rule on the appropriate, or the first set of appropriate disincentives that we are proposing be put in place. So all of that is to say those pieces need to be put in place, but we are certainly hearing a lot from industry about it. We're certainly hearing about certain provisions of it, like the immediacy of the requirement to make lab results immediately available. That's gotten a lot of press attention, and obviously people are doing that because of the information blocking rule. So that those parts of it people are complying with because some of them are complaining about it, and many others, like patients, are celebrating it. And we also have complaint process. We have roughly 730 complaints since April 5th. That's all available on our portal for anyone who wants to go and see the portal. We get roughly one complaint a day on information blocking.
Micky, you mentioned the Trusted Exchange Framework and Common Agreement, TEFCA, a couple of times. I was hoping you could tell us a little bit more about that. What's going on in this area? What does it do? And how's the implementation going?
Yeah, the Trusted Exchange Framework and Common Agreement is, I myself, as I was describing, earlier, my introduction to health IT was actually working to help launch an HIE, a Health Information Exchange, in Indianapolis that became the Indiana Health Information Exchange. And so, they've had a lot of experience from the ground up working with, health information exchanges in state and regional areas. And now we have nationwide health information exchange networks as well, like the Commonwealth Health Alliance and the eHealth Exchange and a number of others. But the congressional direction, looking out at the landscape and saying, okay, we've got a lot of networks now at the state and local level, at the nationwide level, but we need something to tie them together. So that, as I was saying before, we have the experience of having a single network, even though it's totally fine to have a whole bunch of networks. That's good in many ways, because it helps individualize those kinds of services for those participants. But we ought to at least have a basic expectation about how they connect with each other for a basic set of services. And that was the direction that we got from the Congress, was to support or develop a governance and an infrastructure for that kind of connectivity between networks. So that's what TEFCA is. We're working with industry on kind of a public-private model to say, how do we establish a consensus approach to a common agreement, which would say, I can just sign one common contract And that'll allow me to access information from all these other parties and share information with those other parties without having to have individual contracts with every single one of them. Because that's, again, in our fragmented system, that's really hard at that point if you're going to have, sort of kind of the universal basic sharing information we want to be able to have. And how do I have a common technical approach so that we can just basically agree on a set of open industry standards and be able to share that information? So that was the direction that we got, and that's what we've put in place. So we were given no new budget or no new authority. But what we did is we worked with industry. There was a bit of a reset that we had to do when we came in with this administration to make it something that industry would find attractive and that would be a win-win for the public and the private side. But now I'm really happy to report, we've got 7 organizations, networks that have stepped forward and volunteered to be the networks that will be the first set of networks to establish TEFCA-based exchange, where the idea is each of them agrees to sign that common agreement for data sharing, and each of them agrees to implement a technical infrastructure according to open industry standards that all of them agree to, and to allow them to interact with each other on behalf of their participants. So on February 13th of this year, we announced those QHINs, we call them, Qualified Health Information Networks. You can kind of think of them as the AT&T and Verizon and T-Mobile and Sprints of the cell phone world. That's kind of what they are. And we announced 6 of them, and then one was approved later, who were given the green light to implement. So we have, kind of a 2-stage process. One is you have to qualify as an organization, because I think, as hopefully everyone, will appreciate, certainly coming out of the pandemic, this is critical national infrastructure at this point. This isn't like a nice to have interoperability infrastructure. When we talk about the public health requirements that we have, when we talk about the need for privacy and security of our data, I think, hopefully we'll all agree at this point that, all right, this is now something that we need to recognize as critical national infrastructure. So we take very seriously that organizations who are going to do this have to meet a series of tests of their governance model, their sustainability, their ability to do these transactions, their ability to manage security of high volume networks. All of those things they had to demonstrate. So the first 7 QHINs who have been approved means that they have met that first test, that we have vetted them, or our nonprofit partner has vetted them and said, yes, they have the experience and the expertise and the organization's strength to do this. Now, the second part is we gave them the green light on February 13th to implement. And so we're on track now to go live with a set of those QHINs for TEFCA exchange before the end of 2023. And we're really excited about that. And the first stage is using older style kind of standards, IHE standards for those who are familiar with that. But next year, we plan to go live with FHIR-based exchange as well, using these new FHIR API capabilities that are now required to be made available in all EHR systems. So a lot of exciting things that I think are going to be happening over the next year or two with TEFCA.
This has been the Business of Government Hour, a conversation with Dr. Micky Tripathi, National Coordinator for Health IT within the U.S. Department of Health and Human Services. Be sure to join us next time for another informative, insightful, and in-depth conversation on improving government technology and its effectiveness. Until then, subscribe, download, and listen to the entire interview at iTunes, Spotify, or on your favorite podcast app, and as always at businessofgovernment.org.